study investigated the times for Slovenian patients to get access to anti-cancer therapies and how those times differ according to ESMO magnitude of clinical benefit scale. So, in brief, we investigated the times for these anti-cancer therapies to get EMA marketing authorization and then also Slovenian national reimbursement decision. It was 51 anti-cancer therapies with ESMO MCBS score applied by the ESMO expert panel. In addition, then we compared these therapies according to the magnitude of clinical benefit scale for therapies with substantial or non-substantial clinical benefit. And we wondered if those times differ. I may say a bit surprisingly, we found that those times do not differ according to ESMO MCBS scores, according to their substantial or non-substantial clinical benefit. The times were about 1 year each for EMA marketing authorization and also Slovenian national reimbursement. So taken together, it was a little above 2 years for Slovenian patients to get access to these anti-cancer therapies, regardless of the magnitude of clinical benefit. We think that our study should serve as some kind of trigger for both EMA and also Slovenian healthcare public authorities to better integrate this ESMO magnitude of clinical benefit scale into their public health decision making so that cancer patients can gain access to therapies, especially those with substantial clinical benefit, in a time sooner than 2 years.
Well, as we've just seen, that magnitude for clinical benefit study has made an important contribution to the whole idea of ranking different treatments. And here with me to tell us a little bit more about that is Dr. Andre Ilbawi. Hello to you.
Hello, Sarah.
What do you think about this idea of ranking different treatments?
It's an important principle. As we look at what governments are trying to do in cancer care, the current status is we know they're being challenged by increasing number of cancer medicines, increasing costs and complexities of cancer, and a number of patients that is also growing. The impact of that is, unfortunately, the overall budget of cancer is growing, and governments are trying to understand how do we set priorities. So the idea of identifying what medicines have the greatest impact is very relevant to the discussion that happens inside ministries of health and of course ministries of finance as well that are very interested to know what are the implications of the advancements in cancer.
And the WHO has its own sort of rankings, and you don't take price into account, or you do?
So there are different conversations that happen. For the WHO, our starting point for medicines is the essential medicines list, and it effectively tells governments these are the essential ones. Any country, of course, within a certain context, should consider these as the start medicines for cancer and for other diseases. Beyond that, there is another dialogue that happens, which is how do we set priorities from a program standpoint? Because of course, a medicine list is just a starting point. Do we have the diagnostics? Do we have the health workforce that's required for the medicine to be given accurately and safely? So when we discuss these issues with governments, a list is an important reference, but we also have to think about the larger context, the budget, the workforce, the capacity.
In the UK, we have NICE, the National Institute for Clinical Excellence, which is kind of grading and rating which treatments will be paid for by the government and the National Health Service. Many countries don't have that.
Yes.
What do you think about that?
You're correct, Sarah. Unfortunately, many countries don't have this health technology assessment agency, someone that can identify what are the most appropriate medicines given cost, given impact, and given budget for that specific country. The ability to have that agency is a huge issue as it pertains to ensuring that medicines are affordable, both for individuals, for communities, and for the government itself.
So, I mean, why shouldn't countries get a kind of institute like that? I mean, they should, but what's holding them back?
It's a complex question because, of course, there has to be technical experts that feed into the question of is this medicine appropriate for a particular context? And also countries know that they're trying to balance quite a few priorities. It's not just a question of is this medicine relevant, but again, is the system in place, a larger system in place for this medicine to be given in a timely and an effective way?
And presumably there's so many caveats, like this medicine will be good for this patient if they have this condition at this stage.
Exactly.
Is it easy to do, or is it very complex?
So cancer, as you know, is a very complex disease, and this is one of the challenges when we we meet with government officials to explain that a medicine for breast cancer is totally different than a similar type of medicine, but for a different stage and for a different patient. To explain which one should be prioritized is not an easy exercise. We find that reference information, such as the magnitude of clinical benefit, is in fact a useful reference to say, here is some information for you to understand objectively what is the impact, what is the benefit of this medicine, because it's not just as simple as breast cancer patient equals this medicine. It has to be understood that it, again, is a subset of patients, a certain type of condition, and that can better inform who would ultimately benefit from that specific therapy.
Well, Dr. Ilbar, we thank you very much.
It's a pleasure. Thank you, Sarah.